So I think, Dr. Ismail, are you with us? Okay, so the next speaker will be Professor Dr. Santiago Ortega Gutierrez. He is Associate Clinical Professor of Neurology, Neurosurgery, and Radiology, and the Director of Neurointerventional Surgery in Neurology, and Associate Director of Endovascular Surgery Fellowship, University of Iowa. I think the topic title will be very interesting because nowadays, the expansion of the endovascular treatment in acute stroke is a controversial beyond the guidelines. So Dr. Santiago will discuss this very tender point. Dr. Santiago, please, the mic is you.
Thank you so much. Thank you, Dr. Mansour, the committee for the invitation. Congratulations on this interesting and amazing conference, despite the difficulties that we are all facing. These are my disclosures. And over the next 25 minutes, what I would like to do is review a little bit of how we got into the guidelines and the current guidelines we follow for the treatment, the endovascular treatment of acute stroke in patients presented with acute LVO. And then we are going to see what is the current evidence that we have to deal with situations that we currently face very frequently, but for which we don't have a strong evidence. We'll review that evidence and we'll see how we deal with those, and hopefully it will be helpful for your clinical practice. And everybody knows how we got here. We saw Professor Kaplan in the previous talk. He was one of the authors of the culprit paper in 1995 that really started the acute treatment for acute stroke with IVTPA. And even though the therapy seemed to be beneficial for a subset of patients, we soon realized that in certain locations where we have proximal occlusions in acute stroke patients, TPA did not have such a great result. And in fact, the natural history of this disease, even with TPA, was quite suboptimal. As a result, in 2013, despite we all kind of lived this year with quite low optimism, we soon overcame the deficits and the gaps in the clinical protocols for selection of patients by improving the imaging triage protocols and getting better devices to open the vessels. And as such, in 2015, we all witnessed how the implementation of these new triage protocols using sophisticated homogeneous imaging, as well as being faster, as well as having a better study design, we all got the results of 5 consecutive clinical trials that demonstrated that mechanical thrombectomy used in anterior circulation patients has a huge impact in the outcome of patients presented with LVO. In fact, it's one of the strongest effective treatments that we have witnessed, not only in neurology, but also in medicine, with more than half of the patient benefiting from the treatment and having a number needed to treat of only 2.6 patients to help 1, and in achieving functional independence at 3 months. As a result, in 2015, we had the guidelines for anterior circulation stroke in the early window. And soon after, or in parallel, we all witnessed that we were not just happy with treating patients within 6 hours, but also realized that this treatment could have important benefits in very selected patients beyond that time frame. In fact, we knew that the stroke progression in individual patients varied tremendously. Some patients could actually complete the entire MCA stroke within 4 hours from symptom onset. In contrast, there were other subset of patients with great deal of collaterals that could actually, that had a very slow progression and infarct growth over time. And despite they presented beyond 6 hours, 8 hours, and 10 hours, in diffuse 2, it was shown how these patients had still a very small infarct volume. As a result, 2 trials came about to really answer that question and see and test if really mechanical thrombectomy could benefit patients beyond 6 hours. One was the Dawn trial, which was based on clinical imaging mismatch selection, combining age, core infarct measured by MRI or CT perfusion, and in a combination of NIH stroke scale. And the other one was the Fuse 3, which was a pure imaging mismatch profile using the Rapid software that most of you are already very familiar with. Both trials were published, one a little bit before the other, in 2018. And interestingly, in this selected population after 6 hours, the effect of mechanical thrombectomy was actually even bigger than the one shown in the early trials. As a result, very soon, we had the current guidelines, which basically, with appropriate selection, we can treat a little bit of different parameters in the early or late window. We can actually treat patients with mechanical thrombectomy in the anterior circulation and really provide them with a benefit when the infarct is not completed. And we now know that we have two subtypes of population: the slow progressors, which represent more than we thought, approximately 55% of all the patients presented to us, and the fast progressors, which time is very, very important, and we have very little window to treat them, which represent approximately 40% of these patients. And at the same time the guidelines were developed, we also had level 1 evidence to demonstrate that even though in the early trials we used primarily stent trigger devices to perform mechanical thrombectomy, large intermediate bore catheters providing aspiration were equivalent or as effective as stent triggers. Therefore, aspiration with direct aspiration at the clot was also accepted as a very good technique for providing patients with endovascular therapy. That's great, but what's going on now? Well, from all of you who deal with acute stroke patients, we know that the parameters used in the guidelines really do not explain all the clinical scenarios that we faced in daily basis. And one of the issues is what happens when we face patients that are beyond the guidelines. A very common question is this large core infarct. What happens in patients who present with a little bit of higher aspect score, or have a higher profile of infarct, more than 70 cc's, as it was determined in diffuse, or 50 cc's as it was determined in Dawn? Well, evidence started to come up in the 2012, 2013, but this is probably one of the earliest case control studies in which it already shown that when patients are treated with mechanical thrombectomy and compared with controls, and they have large infarcts, more than 70 cc's, they could benefit. There could be a signal. And as you can see here, even though the sample size is small, those patients, there were a little bit of higher rates of independence in the large core infarct treated with mechanical thrombectomy. Soon later, we had stronger evidence from our colleagues from Europe, the ETIS registry. And this registry actually told us that not all large core infarcts are equal. In fact, depending on your, if you provide patients with effective reperfusion, the likelihood of having independence, functional independence at 3 months vary depending on the core of the aspect score at presentation. And some of the patients, the ones between with an aspect 5 to 3, might actually have a decent amount of rates of independence when compared with aspects in the 2s, and none of the aspects 1s or 0s, which basically is not surprising, had any good outcomes at 3 months. When we looked at the meta-analysis from Hermes in all the randomized controlled trials, even though majority of these patients were not enrolled, there's some of the violation of protocols and also some from Mr. Clean that didn't really follow aspects, that we saw that patients with aspect 3 to 5, they still might have a favorable effect from mechanical thrombectomy, whereas the 2s and 0 and 2s, even though we only had total of 37 patients in this group, probably did not. And as a result, the current guidelines state that we have only a level 2B of evidence to treat patients with aspect less than 6 when they present with a proximal occlusion. Because of that, we have now four ongoing trials to try to answer these questions. And hopefully within the next 2 years, we'll have some results available to all of us to help us out how to approach these patients. One is Tesla, which is basically a randomization of patients with large vessel occlusion in the anterior circulation, an aspect 2 to 5, and the symptom onset has to be within the first 24 hours. The enrollment right now, I was told that we have enrolled 93 patients, and the first interim analysis is going to be at 150 for a total of 300 patients. Select 2, which is a combination of CT and CT perfusion, CT aspect 3 to 5, and CTP has to be more than 50, also within the first 24 hours from symptom onset. And this sample size is a little bit larger, 560 patients. Right now, we know that Select 2 has enrolled over 100 patients. The last T, which is one of the arms from the European trials, which is evaluating patients with CT DW aspect 0 to 5, if they are less than 80, and only 4 to 5 if they are more than 80. That's the stratification. Goes up to 7 hours from symptom onset and tries to enroll 500 patients. And finally, also from our European colleagues, Tension, which is another randomized trial with a sample size of 714 patients. And this one goes up to 11 hours for randomization. Well, what about with the low NIH stroke scale? How many times have we faced a patient, a young patient who comes with us with a large vessel occlusion and the NIH is 5? What do you do in these patients? You just treat medically, you wait until they deteriorate and you treat them, or you treat them from the beginning, knowing that obviously every procedure we do carries a risk. Well, some studies have demonstrated that perhaps in these patients, especially in the early window, from Hermes, we know that patients with NIH less than 10 might still have a signal of benefit when they are given mechanical, or when they are treated with mechanical thrombectomy versus best medical therapy and have a proximal large vessel occlusion. This multi-center match analysis also in primarily early window, during the early window, demonstrated that patients who had received immediate thrombectomy when they present within the treatment time window, they might have higher rates of independence when compared with the patients that received medical therapy or underwent mechanical thrombectomy when the symptoms worsen, which is a very important concept because we almost have 3 different groups. The group that seemed to benefit the most is the one that was offered mechanical thrombectomy at admission without waiting for symptom deterioration, even though at that time the NIH stroke scale was less than 6. The patients who actually did second best is the ones treated with medical therapy, including IVTPA when they were within the guidelines for that. But interestingly, when we wait and for the NIH to deteriorate and become 6 to offer this treatment, these patients actually had the worst outcome in this multi-center match control trial. In contrast, another multi-center trials, primarily from Canada, US, and Europe, was not able to demonstrate a different signal at 3 months between these patients, and the outcome did not reach a statistical significance. The rates of symptomatic hemorrhage between the medical management group and the thrombectomy group was not different either, although there was a slightly higher proportion of asymptomatic hemorrhages in the mechanical thrombectomy group. As a result, nowadays, we still only have a 2B evidence to support treatment in this patient population. And as such, we have currently an already started trial called the Endolo, which is going to test the hypothesis if mechanical thrombectomy might benefit patients with NIH presented with LVO and NIH 0 to 5. And it's going to divide the patients in 2 different categories, early and late window. For early window, will be 0 to 8 hours. and they will just treat patients with just CT, CT and CTA if the occlusion is in the M1. But if it's an occlusion in the M2, we also need the demonstration of a perfusion mismatch of more than 30 cc's. In patients beyond 8 hours, all of them, whether it's M1 occlusion versus proximal M2, both have to demonstrate a hypoperfusion of more than 30 or a penumbra area more than 30 cc's. And there is another trial in Europe, the MOSTI arm, that is going to test the same hypothesis in these patients, and they're going to be randomized to best medical therapy or rescue thrombectomy versus mechanical thrombectomy first line, where the outcome is going to be a functional outcome at 90 days. What about the group in which we do a thrombectomy and we remove a proximal clot and then we end up with a distal clot, or from the beginning, they present with a distal emboli, let's say in the posterior circulation, in the posterior cerebral artery, but they have low NIH, but a major deficit, such as hemianopsia or aphasia in the left opercular branch of the MCA. What do we do with these patients? Well, right now, we don't have very strong evidence. We know from the times from IMS3 that perhaps treating these patients might offer a benefit when we were talking specifically at the M2 occlusions. We also know from this multi-center real-world data that treating patients with mechanical thrombectomy in the M2 location might actually benefit distal M2 and proximal M2 might benefit patients when compared with best medical therapy without the additional risk of increasing symptomatic or asymptomatic ICH. When we look at the Hermes, again, even though the number of patients including in these initial pivotal trials of M2 patients is small, we also observe a signal towards mechanical thrombectomy in favor of mechanical thrombectomy when compared with medical therapy. As such, nowadays we still don't have a strong evidence, but what we're gonna witness more and more for these distal occlusions is what we just saw a few weeks ago. We are gonna have more and more studies in which they're gonna specifically test homogeneous clots and compare, hopefully randomizing mechanical thrombectomy versus best medical therapy. And they just came out recently about TOPMOS, which is basically a study in which demonstrated that perhaps offering mechanical thrombectomy to posterior cerebral artery occlusions might benefit these patients. And to finalize the talk, I want to talk about a very also common problem that we face in when we treat acute stroke patients, which is tandem occlusions. Tandem occlusions, as we all know, is basically the concomitant cervical occlusion and a distal ICA clot in a patient presented with acute deficits. And in this situation, not only we don't have very strong evidence, but we have to face, if we want to treat these patients, a lot of questions that we don't have answers for. What do we do? What do we treat first? We go for the intracranial lesion. We go for the extracranial lesion. And if we do for intracranial lesion, how are we going to treat that? And if we go for extracranial lesion, how do we treat it? Do we do a permanent treatment with a stent? Do we delay the stent because we don't know if perhaps we're going to have higher risk of the hemorrhagic conversion by using antiplatelets? What antiplatelets to use if we use a stent? And if we use a stent, if we don't use a stent, when is the best treatment to treat these patients that we might have only done an angioplasty to cross that as initial stenosis? Well, we actually did a recent study trying to, with a survey, a national survey, which the MENA region was also very participative. And we actually tried to really see what's the really pattern of treatment these lesions throughout the world. And from over 220 proceduralists, we realized that there is a very heterogeneous practice on what to treat first, the intracranial versus the cervical, and also how to treat the cervical lesion with acute stenting from the beginning versus angioplasty or other techniques. When we look at the literature, this large study from Stratas, one of the largest thrombectomy registries up to 8 hours, demonstrated that in the group of patients treated with acute stenting in that population, which was approximately 150 patients, actually a stent was associated with better rates of functional independence at 3 months, and surprisingly, without an increased risk of ICH, despite those patients require dual antiplatelets. This large trial, or the large study, is a retrospective observational cohort study from primarily European and US centers, actually showed that or compare the rates of reperfusion and favorable outcomes, as well as symptomatic hemorrhage, in patients with tandem occlusions treated with different approaches. One approach was the carotid stenting with antithrombotics. The other one was carotid stenting without antithrombotics in the initial hyperacute phase, and then after a scan, give antithrombotics if needed. The other one was balloon angioplasty with antithrombotics, and the other one was just thrombectomy alone without trying to treat at all any lesion in the cervical segment. And what it was interesting is that patients who received a stenting and antithrombotics had a higher rate of successful recanalization or reperfusion, as well as higher rates of favorable outcome, in contrary with other people, without compromising higher rates of symptomatic ICH. A recent meta-analysis incorporating the majority of studies that we have up to date, majority retrospective with 2 groups, showed also that it seems that acute stenting might provide with a better rates of best functional outcomes when compared with angioplasty alone, with an odds ratio of 1.43. And then when we look into the few patients that had tandem occlusions in the initial randomized clinical trials, we have not enough evidence to really make big comparisons. As a result, the current evidence suggests that tandem occlusions still remain a class 2B evidence to treat when we treat or perform mechanical thrombectomy in these patients. However, the good news is that there are 2 ongoing trials, and we are trying to start the third in the US, that are trying to address these questions. So one in France called the Titan study, which has enrolled already for 6 months, and the other one from our colleagues in Canada, who are also trying to really elucidate what is the best approach for this patient population. And then without further delay, I just want to again thank you for the opportunity to participate, and congratulations for such a great conference. Happy to answer any questions if you may have.
Thank you so much, Santi, for this very comprehensive and very illustrative presentation about very hot topic of mechanical thrombectomy beyond the guidelines. I think we have a couple of questions from the audience. I think one of these questions is, in the low NIH score, how could you evaluate the importance of the procedural safety for introducing such symptomatic patient?
Yeah, that's a very good question. We actually did, from the data that I presented, the risk of complications of mechanical thrombectomy, and also extrapolated from the clinical trials, is not very large. The risk of a hemorrhagic conversion, it remains low, below 10%, and then risk of perforation or risk of dissection is very small. We actually did a prospective multi-center study with the Cleveland Clinic and the University of Iowa of 20 consecutive patients. And when we that presented single arm, presented with NIH less than 6 and acute large vessel occlusion in the M1 or proximal M2, and from the 20 patients, only 1 patient had a deterioration, which fits with the current literature. About 5% might get a little bit worse, and the other 19 did not get worse or improved. Obviously, we didn't have a control group because this study was primarily a study to assess safety. but it's quite safe in this location. When you start to go to more distal locations, middle vessel occlusions or distal occlusions, since the devices that we have are still a little bit big, although we are getting better, maybe it's a different situation. But for proximal occlusions, we're pretty safe. The question is, do we help? And that's what hopefully we'll be able to really answer when we have the results from Endolo clinical trial.
Yes, and from this statement, I think I have another question regarding the distal location. Do you think in the distal location lesions, with the complication profile of the mechanical thrombectomy and the current profile of the devices and the armamentarium, those subgroup of patient, do you recommend the pre-interventional intravenous thrombolysis in a situation would the patient have to do mechanical thrombectomy?
This is a very, very good question, and I can tell you this is a very, very hot topic. I think over the next 2 years, we are going to start to address, as what I showed there from our colleagues from Europe, we're going to start to really try to assess if mechanical thrombectomy could be equal or superior to IV TPA in distal locations, specifically in different territories. And this is already starting. In terms of how to approach it, I think we don't know how to approach it yet. But the industry definitely is kind of investing in making the devices smaller and even the aspiration catheter smaller to go more distal. But also some groups, especially with the venue of other thrombolytic agents that other than just IV TPA, what about recreating the PROACT 2 trial, going with a small catheter distally and provide intra-arterial thrombolytic therapy in that specific regions? Is it going to open the vessel better than the TPA? And of course, how are we going to select those patients? We need to make sure that we not only open the vessel, but also that territorial risk still has a chance to recover. And I think this is what we're going to witness over the next 2 years. There's a lot of ongoing kind of thought and conferences in regard to this. And as the technology gets better, we're going to maybe see more smaller devices. And probably we're going to kind of revisit some of these thrombolytic agents that are coming up now and see if by doing it endovascular, it can be safer or can be safe and can be better than endovascular therapy. We have to do it in a way that through a strict control randomization trials in order to make sure that we really don't do, we do not harm patients, which is the most important thing here.
Thank you, Professor Santi.